Roy, I'd like to turn to you again a little bit as somebody who's been involved in investigational therapies, throughout your career, and looking now at what are new promising single agents, immunotherapy agents, and what combinations excite you as we go forward.
We want to combine and combine in a rational way, and so this field's wide open. In fact, if you look at some of the data from the SITC, I think there were well over 900 trials ongoing in the immunotherapy space. And I have a slide that I use when I lecture just on trials that in lung cancer, combinations with PD-1 and PD-L1, and I'm ready to make a second slide because the number keeps getting larger. So there are many things moving forward, but of course I think first you have to ask, what's the target? Is it present in the tumor? Or what are you modulating, and do very good, careful phase 1 work. So the way I like to think about it is, you have agents that can, if you look at the T cell, just focusing on the T cell, that either stimulate T cell or are checkpoints that inhibit the T cell. So you can imagine you could make antibodies or molecules to target both. Certainly, we've been working on PD-1, PD-L1, that's a given. CTLA-4, I think that's very much in play right now. The data in melanoma are quite compelling. Most of the trials are looking rather positive, some marginal. In lung cancer, we just don't have the phase 3 data yet. I think in the next year we'll have the data from the MYSTIC trial, which I'm sure Nair can update us on, and the Checkmate 227 trials. We know that the MYSTIC trial didn't hit its interim analysis in PFS, but it still has an overall survival, which is, of course, the ultimate endpoint pending. So that makes a lot of sense. Other checkpoints to think about, LAG-3, TIM-3. At the ESMO meeting recently, there were so many groups presenting their molecules to target those other checkpoints. Then you think about something called 4-1BB. That's on the other end. That's puts the gas on. Certainly, if you use that, you'd want to release the brake. So one of the checkpoints, but those agents are quite well moving forward. And then you name it, there are targets. There are vaccines and trying to stimulate neoantigens, personalized vaccines that are ongoing in lung cancer. There are bispecific antibodies. What's that? That's an antibody that might target an antigen on tumor, but also target CD3, which is going to bring in T cells. Those are ongoing. There are early targets such as TIGIT and others that are being studied. And then there are things that are working on the immune microenvironment, adenosine and CD73 and CSF1R, looking at macrophages, the macrophages being involved in inflammation. And really we could talk all day. So and then finally VEGF. I think one thing that's very interesting is, back from the old ECOG trial, bevacizumab plus chemotherapy. Now there are some data that I think do suggest that angiogenesis plus immune therapy does have some potentials for synergy. Why? Because angiogenesis inhibitors increase blood flow to tumor, so you get more T cells in the tumor. There's also an effect of inhibiting VEGF on improving presentation of antigen to the T cell through the dendritic cell mechanism. So I think we're going to be seeing more of those, either with bevacizumab or with ramucirumab, pembrolizumab, for example. There's IDO. There's so many agents. So I think that what we need to do as investigators is have these trials available for our patients, but also always ask, what's the rationale for it? Are we obtaining tissue? And in that, I would say fresh tissue whenever possible, but tumor, plasma to really analyze. And I think we'll slowly move forward in this way. And the lung maps testing this, as we've talked about, and certainly other single arm or multi-arm trials, coming from different groups.